there's been a big increase recently in the demand for endoscopy, and that increase is set to continue over the next, at least over the next 4 years or so. And the projections from the Cancer Research UK document from last year are that there's going to be a 44% increase in requirements for endoscopy in the UK. The biggest chunk of that is because of bowel scope. That's the that's a polyp screening test for 55-year-olds, which is due to be rolled out nationally. But also there's been a change to NICE guidance, so it's easier for GPs to refer patients up for an endoscopy, be it an upper or lower GI. There's more surveillance going on, people are living longer, so there's a variety of factors. We can group endoscopy innovations into two categories really. So we can look at new technology that's coming up, and for instance the improved optics of modern scopes will allow us to save money because we won't necessarily need to send polyps off for histology, and that will make things, that will sort of balance the books a bit more within endoscopy units. But also the innovations I would most like to see are the day-to-day working efficiencies that we can achieve by looking at our service and trying to take out the waste, so all the things that aren't really contributing towards patient care, and allowing ourselves to get more patients in and get more patients out, so we can start tackling this mountain of endoscopy that we're currently faced with.
This comes from the NHS Atlas of Variation, and this is a heat map looking at the amount of endoscopy per head of the population, and you can see there are some areas like Northumberland which are fantastic at colonoscoping their local population. They have very high rates per head of the population, but there are other areas, the pale areas, where they're doing less endoscopy, and if you work in one of those areas, then perhaps the impact is going to be even greater as you're forced to come towards the mean.
Because the primary clinicians need to understand the current guidelines from the NICE and the pathways quite well, and work with the secondary care. We discussed about direct to test, and for direct to test to be effective, it is important the primary care clinicians use the appropriate referral systems, so that we are not duplicating investigations, or we are not performing inappropriate investigations.
Now, of course, there is always plan A. You can always chuck money at it, and that's obviously what a lot of units have done in the past. We've got ourselves extra rooms, we've got ourselves extra colleagues, we've insourced, we've outsourced. That's all fine, but what I would say is that if you're not fixing the underlying issues in your endoscopy unit, then the problem's not going to go away. And yes, you can paper over the cracks, but the demands on our endoscopy service is so great that I think it requires a fundamental rethink of how we do endoscopy. I honestly believe that there are things that we can do to make lives better for us, and I promise you, you find that if you start this process of service improvement, you'll find that by engaging with your staff, because of course nurses and everyone who contributes to an endoscopy unit, they've got their own ideas about how to fix these things, they'll become happier, and your patients will become happier as well, because you always start the process by thinking about the patient and placing the patient at the centre of things. And the most important thing is just to understand that it does have to become part of your everyday working. It's not occasional annual audits. This needs to be part of your endoscopic DNA.
I think transnasal endoscopy, as mentioned, is an exciting tool. It's been around for quite a while. It's not an entirely new concept. It was brought onto the field by Professor Reza Shaka from Wisconsin University in 2004, and gradually it was adopted mainly in Japan, where they have a very high prevalence of gastric cancer.
Why transnasal? So in essence, endoscopy and upper GI endoscopy remains one of the most uncomfortable tests we give our patients in endoscopy, and this mainly relates to the fact that we deal with the glossopharyngeal afferents, which are the things that trigger off the gag reflex. And if you look at this this cartoon, you can see that most of the glossopharyngeal afferents, which are the source of the gag reflex, are housed at the back of the tongue, and this shows you that also the uvular and areas in the back are going to trigger it off. So it's no wonder that patients feel uncomfortable even with the use of sedation. It's not new technology, but we keep on revisiting it, and I think in this current climate of pressure of capacity v demand and pressures on streamlining services and making ourselves more efficient, I can show you how this technology is, I think, now in prime time. It's accepted much more widely, and I think we've got the instruments that can deliver.
Although the biopsies are taken from a smaller forceps, or taken by a smaller forceps, which is about 2 millimeters in diameter, there have been various studies out there. One I can quote you from Thierry Ponchon in France a few years ago. We had done a study at St. Mark's when I worked there, which all showed that although the biopsies are small, if taken correctly, they don't actually impact yield. So there's no real concern about making a diagnosis histopathologically. Although they're small, they are good enough overall. And I think that people should not be put off the idea of it not being at least equal diagnostic tool.
You need to convince your trust that there are advantages, okay? Rapid recovery, rapid turnaround, what you invest in the preparation to make sure your patients are actually comfortable, you gain by having a rapid recovery without the need for sedation. It is ideal for the one-stop shop clinics.
I think transnasal endoscopy looks like the way of the future, really, in the sense that I've heard it described. It's going to mean a better patient experience, certainly. It's going to mean more patient throughput. It's going to mean the outcomes are better. There seems to be less complications arising from it. Now, I'm not a clinical specialist, so I can't comment, I can't say this is going to be where it's at in the future, but certainly Ed Despot gave a very convincing analysis of it. So from layman's point of view, I think that looks like how I would want to have an endoscopy. Certainly I was persuaded, and I think most other lay people would be from that description.
The reason for our focus this year being on transnasal endoscopy is essentially because it's what our customers are telling us they're interested in. Olympus for many years has had a transnasal solution. We now have a 290 series transnasal solution, so that's relatively new to the market, and it's got lots of additional features. However, it really responds to what our customers are telling they need. We actually completed a survey with our customers, and over 20% of them replied saying that they were considering starting a transnasal service within the next 5 years. So really the focus for this is demand from our customer base. The role that Olympus can play in light of the demand for diagnostic tests would be to put the correct technology in the hands of clinicians. With our additional technology, for example MBI, it doesn't detract from the quality of the test, but together with our transnasal endoscopes, you actually get a faster result, which means that you can do more patients with the same level of technology.